Hi, everyone. If you are watching us via our YouTube stream, we are behind the scenes with our panel. This is Eric Glazer, Bright Spots in Healthcare, and we are going to get started in about 15 seconds, but just wanted to get you all set up. So welcome. Here we go. Welcome behind the scenes. All right, folks, we're going to go live, and hopefully Cynthia will join. I'll be looking at the Zoom chat, Sherry, or my phone for any updates on your end. And let's rock and roll. Hi, everyone. Happy holidays and welcome. This is Eric Glazer, and you have joined the live recording of Bright Spots in Healthcare. This is produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around the country. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared on our show are able to be applied at your organization. We believe that this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. I encourage you, if you have not already, to subscribe to Bright Spots in Healthcare. Every one of our live episodes, any one of our recorded episodes goes into our Bright Spots in Healthcare podcast stream. You could find us anywhere you consume podcasts: Spotify, Apple, Google Play, Stitcher, all of them, Amazon. We have a ton of incredible guests that we've had on throughout the year talking about evergreen topics that can absolutely add value to your organization. Don't subscribe to listen to me. The guests are tremendous, all adding value through bright spots and examples. I encourage you to do so. This will allow you to get more information and help you help your consumers, your patients at whatever organization you are part of. So thank you in advance. Take a look at it. And if you like it, please do rate us with 5 stars. That helps us build the show, build our audience. And that, of course, helps us produce more great content for all of you. So thanks in advance. This episode is compliments of our friends at Icario Health. Icario is a health action platform, and they unite pioneering technology, data science, and behavioral insights to connect everyone to better health. You could check them out on their website at icariohealth.com. That's spelled ICARIO health.com. My words to describe them: they've been a partner of the show for a while. Really enjoy working with them. So these are my words, not theirs, but I view them as one of these unicorns in healthcare because they combine what I call innovation with pragmatic non-healthcare thinking. I'll get into that later, to drive better healthcare outcomes for all of you and all of the people you take care of and ensure. So I'll tell you more about what I mean by pragmatic non-healthcare thinking and a little bit more about Icario later on in today's episode. I'm going to bypass bios of our panelists in the interest of time. If you've not reviewed them via email, I think we sent you a link. Our producer, Sherry Keels, is going to post them in the chat so you can get a sense of some of the expertise you're about to benefit from over the next 45, 55 minutes. And also at 12:15 East Coast time, you're going to receive yet another email from me. I'm going to be asking you for your feedback. You regulars are probably familiar with all of that. We take the feedback you provide us seriously. We're in the process of firming up the end of Q1 and early Q2 programming right now. And I really want to make sure I'm covering topics that are important to you so that we continue to earn your trust once a week for an hour with the content we're able to put out here so that you could be able to do a better job at your organization. So please take that feedback form. It'll show up in your inbox for those of you here live at about 12:15 East Coast time. So thank you. Today's episode, strengthen case studies. We're going to focus on case studies today. We're going to talk about strengthening the member experience to improve quality ratings. We're going to cover a lot of interesting components of behavioral design, data insights, and you're going to hear some examples from our esteemed panel. So I'm going to jump right into it. I want to talk about non-healthcare stuff briefly. I want to learn about benchmarking from the finance industry and what we could learn from them. And so I'm going to bring in Topher Wurts. He is the partner and chief marketing officer at Chief Outsiders. Topher, how can you take your experience, because you work, I know, with both the healthcare industry and the finance industry, how can you take your experience from the world of finance and apply some of that experience to, let's say, a regional blues plan and being able to use data and target members for engagement?
Sure. So most of my career until 6-8 years ago really was Wall Street and finance, large capital markets, market data, real-time information, algorithmic trading, portfolio optimization, all that kind of stuff, Eric. So, what we used to joke that we thought that healthcare would follow right behind us as as things, we got into T+1 settlements, all that kind of stuff, and it has. So about 8 years ago or so, started to work in providers and payers, and what we really started to do was apply that kind of methodology and thinking, very similar to what we were doing in the financial service industry. So it's a data-driven approach, it's a big data approach, algorithmic multi-factor model type approach. Apply that to the member data, both internal data, claims data, and so forth, and external data, social determinants, social isolation, food insecurities, these kinds of things, right? So that we could really build a results-driven method to go after the members. And so, this really came to play at the peak of the pandemic, where we were identifying the people that needed the most support in a very large state Medicare plan, and we were working with them directly based on analytics and analysis and member to make sure that we were calling them, providing them support outside of the common benefits that would really deliver them important support. And I think we did a great job in the plans that we worked with during that time using that method.
Sorry, hadn't mute on. Do hundreds of these shows. I still get caught with my mute button on. So could you give us an example of, let's say, applying this fundamental approach or philosophy, let's say, to we'll throw, like, say, a blues plan, let's say, and during the peak of the pandemic, let's say, how are you able to use sort of this methodology to understand who needs help and who a plan would need to really focus some resources on?
Yeah, so we were able to go county by county in one state, and so, for example, we'd start to look at folks that the model was saying had social isolation issues, members that maybe couldn't care for themselves in the way they could when really everything shut down very suddenly. So with that data, we were driving 40,000 outbound calls a day, mixture of different approaches there, of course. But a good example might be we reached a member who she had a helper. She lived independently, but she had a helper that would help her with basic household chores. Our outbound call person research, she was very upset that her municipality was calling her and citing her because her trash cans were still out. That's how fast things shut down. And wouldn't be a typical service that a Medicare plan might provide. But our outbound call person was able to identify help for her, get those trash cans up the driveway for her, and the municipality's happy, she's happy. It was so important to her, that little thing, and we have dozens of examples like that occurred during those many outbound dials that we were doing every day, Eric.
That's great. So I'm going to bring in Louise Briguglio. She's the Senior Vice President of Integrated Experience at Icario. And Louise, could you talk a little bit about data methodology and how, from a data methodology and analytics perspective, you could think about taking what Topher was talking about and making sure we avoid any mistakes or pitfalls? Because my guess is, as simple as Topher made it sound, there's all kinds of mistakes that we could potentially make. And if we're truly trying to leverage good data to actionable insights, we need to avoid pitfalls.
Yeah, and I'd be happy to. Yeah, and like, Topher explained, there is such an asset that a lot of health plans have, that a lot of health systems have, which is you truly have big data, right? You have so many people you're touching every day, and you really have a fair amount of information about them. But to your point, Eric, there's ways that you want to leverage that data, and then maybe some traps that you can sort of fall into. So what I like to do is I like to sort of frame up three things that also, no matter where you fall on sort of the data savvy spectrum, you could probably kind of pull into your business. So first, it really starts with getting the question right? That's going to frame up all of your inquiries. So you got to get that right. Two, if you're thinking about moving into AI ML, which we do a lot of, there's a couple things to think about there. And then thirdly, it's really about finding opportunities to pair that quantitative research with some qualitative research if you can. So starting with the idea of the right question, usually when we're thinking, well, how do I use my data to solve a business problem? We're really stuck in the business problem that we're trying to solve. And what that often leads you to is to kind of think about the problem in the context of your business. Often people start by saying, well, I really need to understand our population better, which is a great place to start. And so they say, okay, I want to do research on Medicaid members versus Medicare members. Or maybe I want to think about people in the Northeast region of our business versus the Southeast region of our business. And the way you're framing that question can actually lead to a fair amount of bias in your study, right? Because first of all, we have to ask, well, is that what matters? So the really important thing for people to do is to actually start with the outcome that they're trying to drive. And certainly sometimes, perhaps you're trying to understand attitudes or beliefs in the context of a marketing initiative, but lots of people in the healthcare are really in the business of driving outcomes, right? So it's important to start with that outcome. Say, if our goal is to get people in to see their doctor, their PCP, what can I say about people who go to their PCP versus people who don't? What about people who go regularly on the clock versus people who kind of go sometimes? So really just that simple reframing of start your question with the outcome that you want to drive and make sure that you're looking for the connections or the similarities, or like we talked about, the propensity and the predictive patterns drive, not the way that you think about your business. So that's really important to getting the right answers.
Go ahead. Keep on going. I have a follow-up, but I'll wait. Go ahead.
Okay, I'm happy to have a jump in. The second piece that I was talking around AI and ML methods. So first of all, you don't have to use AI ML. I know it's a buzzword. It's been a buzzword for a long time. There's a lot of really great business transformation driven on pure analytics, and this is coming from a company who's very invested in AI and ML. But I never want people to think that because I don't have that, I won't be successful. It's not the case. However, one of the really wonderful things about AI ML is it can actually be really helpful, again, at moving that bias that is sometimes in the human heads about what really matters and what really doesn't. So for example, when you start using AI ML, you take that end action. You say, I want to understand who's going to the doctor, why they're going to the doctor, because I'm trying to get people to go into the doctor. So what an AI ML model can do is it can say, okay, I'm going to try to see if I can predict who's likely to go to their doctor and who isn't. And I'm going to tell you, my dear researcher friend, these are the attributes. These are the things I need to know in order to predict that accurately. So these models will then put forward, I need to know these 17 things. One of those things is income. One of those things is whether they're in an urban versus a rural environment and so you can see how that methodology starts to maybe eliminate some of the human bias and instead drives it by data. The last thing, so I wanted to tell you three things. The last thing I would say to keep in mind, though, as you're starting to use these methods, whether, again, you're using analytics or you're starting to move into AI and ML methodology the way that Icario and some others do, is that pairing that with qualitative research, getting out in the field, talking to people, it's really important because that's going to help you understand the why of it, right? So the data can sort of point us to the what. But really making sure that we understand, well, at the end of the day, why is this particular group of people, or why is that factor so important, or what are the barriers that are actually preventing action, is really the key to sort of rounding out the picture that you need to start to transform your business, transform your services, and get that behavior change that you're driving folks toward.
So, Louise, to summarize that for us, 1, 2, and 3. 1.
Start with the right question. Yeah. So, and that question needs to be about the outcome you're trying to drive. So rather than starting from a question oriented on your business, this market versus that market, start with who goes to their doctor, who doesn't, and why. Second, what I would say is consider using AI and ML models and know that they can be helpful for eliminating bias. But again, if you don't have that capability in your organization, don't be intimidated. Use your data anyway. Use basic analytics. Thirdly, is start pairing that with qualitative research if you can. So actually getting out into the field, talking to members as you're starting to see those trends popping through in the quantitative data, round that out with the story of what people are really facing day to day.
Well done. I do have my follow-up question. And by the way, folks, you can help co-moderate. There's a Q&A module. Jump right in there. Sherry and I, my producer Sherry Keels and I will be monitoring that, and we could integrate your questions into this conversation. So, Louise, how do you make sure you alluded to this in your answer to number one? How do you make sure you're measuring what really matters and what's important most?
Yeah, I think a really important thing, and this again is sometimes it can help, I sort of talked about how qualitative research maybe follows. It can also help sometimes to start with a little bit of qualitative research. So for example, really understanding what matters to your population. Certainly within the health plan space right now, there's a lot of focus on member experience, member satisfaction. And I think a really important thing is that understanding that their experience, their satisfaction, what they want from their health plan can actually look really different from perhaps what they want in terms of success and experience from, say, their provider. And so something that you could be aiming towards and delivering, you're saying, well, this is the outcome that matters, can be totally different. If you don't have that conversation, you don't really understand what matters to that member. Similarly for health outcomes, right, is, I may not phrase a health goal in the same way that a clinician would. The way I, as a consumer, might phrase my health goal is, I want to be able to go to my grandson's graduation. That's the outcome, that's the measure that matters. So the more that folks who are trying to move the needle on these things can make sure that they understand that outside-in perspective, often of the population, perhaps of another key stakeholder group, depending on what you're trying to move, also generally the more successful the initiative will be.
All right, I'm going to bring in now Cynthia Weiss. She is the Director of Quality, Accreditation, and Wellness at AvMed Health Plans down in Florida. Cynthia, now at AvMed, you took a little bit of a different approach to the data, but still executed a program that dramatically improved member satisfaction. So I'd like you to tell us a little bit about AvMed so people have some perspective. They haven't heard of you. And then the program you have in place to both close gaps in care for better HEDIS scores and star ratings.
Thank you. Yes, so AvMed is a regional health plan in Florida. The concentration of our members is in South Florida, but we do have membership throughout the state. We have about 213,000 members at the present time, and we have about 22,000 Medicare Advantage members.
And can you tell us a little bit about a program that you have in place that maybe doesn't rely on such detailed data analysis to choose your member population, but has been very effective in driving the outcomes that you're looking for within your Medicare population?
Yes, thank you. So we have a program that we call Healthy Perks. It has been we've had it going for about 5 years. We're going into our 6th year now with Healthy Perks. And it is a wellness reward program that we have designed around many of the STARS measures. We do not, for the most part, we do not use targeting for this program. All of our 22,000 some odd Medicare members are included in the population. And for most of the activities, members are able to participate and become rewarded for those activities. We decided on the front end that we wanted to make this something for everyone, something to delight and inspire our members toward a healthy lifestyle, preventive care, etc. And so we didn't want them to be excluded because they did not have a gap in care or they did not have a chronic condition. So we do have age and gender specific activities, but for the most part, most activities are open to all of our members. In fact, we have about 8 to 10 activities each year that are available to all of the members. The kind of activities that are included are annual wellness visit, bone density screening, breast cancer screening, colorectal cancer screening, and the incentives range from about $10 to $25 per activity, so not real huge dollars. And for last year, we offered $100 maximum for the year, but for this year, 2022, we offered $125 maximum annual reward value. Our program is an attestation-based program because we decided that our claims data is not perfect. We have gaps in even our claims data. There are some measures like colorectal cancer screening that go back for a long period of time. And so we may not have your claims information on that. And so we decided against primarily not targeting specific members to avoid abrasion and to make it kind of seamless for the member.
That's great. So let's go through that. So you focus on those 10 potential actions. You focus on member attestation to remove the friction. It also probably makes you less reliable on the data stream too, right?
So we don't know for sure if what members are telling us is the truth. We have done some little sample studies to see, and our Medicare Advantage membership is about 97% consistent with what we see in their claims. So either we might be missing a claim when we do the study, or there might be a few people who are, not being 100%, or they may not quite understand what the activity really truly is. Some people think a bone density screening is the same thing as having a broken arm x-rayed. And so there can be some misinterpretation in some cases. But we're able to act quickly, and we're able to not leave out members who might actually be part of the population, but our claims information is just inaccurate.
I like that. So you're basically, despite you having access to the data and the analytics and a lot of things that Topher and Louise are talking about, you're saying, hey, the resources required and the friction it causes with the member may not be worth it. Let's just create as easy of a process as possible to participate. And then we'll use the data retroactively to see if the program's being effective, and if anyone's sort of gaming the system, then we could recalibrate how we run it. How long have you been running this program? And then take us through, I know you launched it right around February, kind of after all the noise of the holidays. Tell me a little bit tell us how it works and what a member experiences.
So we have been running the program for 5 years. 2022 will be our 6th year with this program. And it basically is to enable our members to not only remember and be encouraged to complete activities, but also to educate them about the importance of the activities. If all we accomplish is for members to open up a communication and read the information and understand why things are important for them to complete, then we've actually accomplished at least one of our goals. And then the hope, the dream is that they will follow through and get those activities completed, that they will attest to and be rewarded and have a wonderful experience with AvMed, and ultimately, all of the multi-pronged goals of the program will be achieved.
So that's a lot of what I would call, I can imagine people listening right now are thinking, geez, that's a lot of operational nuances that we would have to incorporate into our organization. We're a big health plan. We're bigger than AvMed. It's too much bureaucracy to be able to put all those things in and take advantage of such a good idea here. How are you guys actually operating it? How are you executing it? Because it does seem like a lot of moving parts.
So there are a lot of moving parts, and we have partnered with a vendor in order to administer this program. And for a company the size of AvMed, that can be very important. There are things that we're very good at that we can do in-house easily. And then there are things that really we can benefit from the strength of a vendor. And this particular program is one of those.
And that vendor is?
And that vendor is Icario.
Oh yeah, cool. So they just come in and turnkey it and then partner with you on reporting and data and the overall rewards, executing on the rewards.
Absolutely. The only real requirement is an eligibility file. To that, we do, for some specific targeting, we do flag certain members, but for the most part, it's very, very turnkey.
Cool. Let's talk about, let's shift back now. We've now heard a little bit about data. We've heard a little bit about pitfalls and avoiding pitfalls in data. We've now heard about a program that relies less on the front end for data, but more on the back end. Let's talk about integrating now data to create actionable insights and driving engagement. So Topher, how let's say we'll call it a regional plan. Let's make up a Blues plan. How are you driving meaningful engagement, let's say at a Blues plan, and also providing an exceptional experience that not only hits all the consumer, hits all the different quality goals that sort of Cynthia is working at, but maybe in a commercial population?
Yeah, I think there's a couple things in Cynthia's segment that are really noteworthy. My work has generally been in very large populations, 750,000 plus populations, maybe 2/3 of that are concentrated in some very large groups, and so forth. So, what's fun about looking at what a plan like AvMed's doing is that you can provide a very personal level of connectivity at that size. So what do you do to scale that? And certainly one of the things that she said that was the fear around the self-attestation piece. We've done a ton of research around that, and there's exactly those kind of 97% numbers and stuff translate. It's really not something to be fearful of, and it's so much better an experience than trying to map it to a claim and all the time it takes. So anyway, so how do you take that very personal approach you can have in a relatively small plan and scale it up? Well, you have to do some segmentation. You just couldn't afford that at a huge scale. So you've got to try and figure out by combining the data and the insights to drive the engagement at the right scale. So in a very big plan, maybe your complex care management area that's providing a great experience, a high touch model. I mean, let's face it, provider and navigating providers and specialists in a Medicare population is tricky for everybody, but there are certainly certain segments of members that are having specific experiences around their area. So by combining that, we've been able to data and analytics, we've been able to take, and create these cohorts where we can expand care management from a very small population to many cohorts that are much more targeted. And then as a result of that data-driven approach, we can provide lighter weight touches at scale than a complex care manager nurse maybe is doing in a very small part of the population. And thereby, combine indirect contact, maybe IVR outreach or setup. We're looking at other technologies like SMS to AI to engage people and so forth in these different cohorts, and then get them connected to people that can really support them, in right where they live and what they need.
That's great. I love, and it also provides a much more optimized use of the resources at a health plan.
That's right. So we use a whole variety of resources. Some things are self-service. A great program that ties to sort of the HOS, mental health area can be a completely automated listen and earn program where members are provided an incentive to enroll, a member to complete. It's completely scalable and so forth. That might be a very lightweight example, something that we've done very successfully. And of course, you're hunting HOS members. The CMS is weights more towards consumer experience in the two surveys, CAHPS and HOS. In a big plan, that's like hunting needles in a haystack, Eric, right? So a program like that can be fully automated is great. And then the next tier up, things that we can do with non-clinicians, make many calls, many connections, help members in that way. And then a tier up from that, we use pharmacists. What we've learned is that pharmacists are are super trusted in the chain by the members. And so when a plans pharmacist calls, it's almost like a provider level connection. And so then they can help with more complex cases. So we can build, using an analytics and data-driven approach, cohorts that map to different levels of connection, and then use incentives and things in these different areas to really help members around their specific issues where they live.
Could you tier for us the approach for outbound? Like how are you going out and reaching out and doing it at scale in a way that's effective, but you can afford it?
Yeah. So what we do there is we do the segmentation, we do the data analytics up front, we create the cohorts, and then we go right from that bottom tier, which is maybe just a very specific direct mail piece, with educational information, to an IVR approach to some members, to non-clinicians. I mean, during the peak of COVID, I think I mentioned we're making 40,000 outbound dials a day, obviously a lot of non-clinicians, to the pharmacist group, and then to the complex care manager. So it builds just like that in a very big.
How do you, so non-clinical script, so IVR, obviously you can't mess that up. That's automatic. Pharmacists, you figure they're trained and familiar with that kind of engagement. Same with the complex care managers. But for the non-clinical folks, it seems to would be taking a big important bulk of those cohorts. How are we making sure that they're delivering what they need to deliver and executing in a quality way?
So we use an old marketing and software development approach, right? So each cohort that comes from the algorithmic model gets a persona. The persona defines what we're going to do. That creates a script with branching logic in it. It's implemented in a tool that the non-clinical staff can follow. So it's scripted, it can be approved by CMS, and they can work that cohort with that script. If they do get stuck, then we take that member and put a pin in that. We're going to get back to you, and then we'll bump it to a pharmacist, when needed.
So are the pharmacists, so if we're talking, let's say, about a Blues plan, where's the IVR coming from? Is that from the Blues plan or a partner like Icario, the non-clinical scripted, the pharmacist? Like, where are they? Where are these resources coming from? Because I could just hear people listening, spinning, like, how are we going to do all this?
Yeah, so we use Icario a lot for IVR, for the multi-series incented program, listen and earn type program around mental health. So that was their help was really important to scale this quickly.
All right, so let's bring in Icario back in here. And Louise, how can we do a better job now? Because it sounds like I see all the framework for all of this. How do you go about understanding a consumer's propensity to engage in healthcare? And once you get that understanding, like, how do you convert that to information to drive meaningful action?
Yeah. So, again, like we talked about, understanding propensity to engage, it starts with, using your data set. So, you've got data about outcomes and who's done what and who hasn't done what. And so really working backwards from there to understand their propensity to engage. So use that data and use it right in a way that's really anchored on the outcomes that you're trying to drive. I think the second half of your question, right, is maybe that's a thornier area, and one we haven't talked about. Well, how do I now actually get the behavior, and how do I drive them to act? And so there's a few things that we like to talk to folks about. One of which is to realize that often the place that we start in healthcare, because frankly, a lot of us kind of lead with our brains in healthcare. We're thinkers, we're system thinkers. We often tend to lead with the idea of education. So if this member knew what I knew, surely they would do this thing that I want them to. If they knew what I knew, they would have already gotten their vaccine. And so we tend to lead with education, and education is incredibly important. There is no doubt that it is tied to outcomes. Higher health literacy leads to better health, better outcomes. The problem is that getting that action doesn't start with education. So the first thing you have to do is you have to actually create a desire to act. So all of our programs that are, geared at getting a behavior really start with understanding, well, why does somebody want to do something? And often that's frankly getting into people's psychology. Some people will do things because they feel a certain sort of peer pressure. And believe it or not, it's not just teenagers that works on. Just simply everyone your age, people who look like you, here's the data, are doing it, right? That creates a desire like, oh, I'm non-conforming. I'm an outlier here. Right? And that will really work with certain folks, but it won't work with others. So the first step always has to be create that desire, right? That's the activation energy that can drive through the rest of the experience. And then education is actually more a form of barrier reduction. So, right, first you have to break inertia, create a desire to act. Then education can come in once you've created that, like, oh, maybe I should be doing something. Tell me more. And education is, here's where you're going to go. Here's how you're going to do it. Do you have this barrier? Well, here's a way you can get around that barrier. So then education can kind of swing in to grease the tracks. So that's a little bit, I'm keeping it all very high level, but that's really how we tend to think about, okay, how are we going to move this member or this patient all the way to the end stage? You really have to kind of think about those two things separately. Desire to act, one, create it, because it may not be there. And then two, how do I reduce barriers, right, and reduce friction? And part of that is going to be education.
Right. All right. So what I'm going to do here, folks, is there's a couple of questions that came in from the audience. I'm going to bring those questions in. They're right on point. So good job, whoever submitted that. We're going to have Topher come in and share a really cool bright spot on how to drive a culture of empathy at your health plan. We're going to learn about what Cynthia would have done differently if Cynthia was going to start the Healthy Perks program all over again. You heard about that great program. There's a couple of learnings she has. She's going to talk about what she would do differently. We're also going to cover sort of a bright spot that was born out of the pandemic that could be leveraged for non-pandemic time if we ever have that time. So we have a lot to cover here in the last 23 minutes or so. I do owe you guys I talked about non-healthcare pragmatic thinking and tell you a little bit more about Icario, who is supporting this episode and has supported the show all year. So I do want to do that so you have a good understanding of the potential resources you have right in front of you or at your fingertips. They are, again, a health action plan that deeply understands, as you could hear from Louise talking, people and how to use behavioral research and data science to move people to take better action. And I love when they talk to me about they're trying to bring humanity back to healthcare communication by delivering a whole person solution. And you can probably hear that just through all of our panelists and how they're talking about their programs right now. They intelligently reach members that need the healthcare interventions most, while at the same time driving those low and moderate acuity members, as you heard Topher talk about, with personalized outreach at that scale. And that's sort of, that ties back to what I said at the beginning of the show about pragmatic non-healthcare. They take a very consumer-oriented Madison Avenue approach to understanding an individual's values. So if you think about the brands that engage you, and even to do things that we probably shouldn't do, like PepsiCo, for instance, or Coke, maybe more generically Target. They take words that inspire behavioral change. These companies all drive us to a behavior. Because they want us to consume and purchase their brands, right? Well, if you want to move the needle in population health, I'm telling you, you need to, and value-based care especially, you got to think outside of healthcare right now and think about engagement differently. And that's why I think Icario is a true bright spot. I encourage you to reach out to them, because even if you don't hire them, you're going to learn things. And you probably learned things from Louise just today in the short time she's been speaking in front of you. So pick their brain for ideas. They have a ton of experts on how to personalize the healthcare experience. I encourage you. They're good people, really thoughtful in their recommendations. And in fact, if you want, I'll do this, Sherry. I'm going to put you on the spot here. If you want me to make a personal introduction to someone on their leadership team, I've gotten to know them well. Let me know. No pressure here, but I'm going to put up, for those of you attending live, a poll, or Sherry's going to put it up. She's scrambling right now to put it up. There you go. Worked it. And then if you are listening on a recording, why don't you just email me at eglazer@sharedpurposeconnect.com. That's my personal email address. And I'll make a personal email introduction to someone at Icario that could answer some of your questions. All right, let's get now to empathy. And I think to execute a lot of these things, you need to really have a culture that takes the end user's perspective and thinks about that all the time. And that's easy to say. And if you're a nurse in a management role, you probably have that. If you're a physician in our audience, you probably have that. But most of us at a big organization, you lose sight of what it's like to be someone who's in need. And so Topher, you had a really good example at a Blues plan of what they're doing to drive empathy as a strategy at their organization. Could you provide an example of how this was deployed and maybe inspire some thinking from our audience right now and bringing it to their organization? How
Yeah.
can you go ahead?
Yeah, sure. The example you give, the plan is led by the Medicare plan is led by an executive who's a huge Simon Sinek fan. People don't buy what you do, they buy why you do it. And she has a great example of her mother sort of sitting on the floor, at the end of a long cancer battle, surrounded by bills and stuff. And so what we were tasked with was, in a plan of that scale, with that many people that are working so deep in the organization, very narrow areas, claims or data or compliance or whatever. How do we really bring to life that the reason they're coming to work every day are these members? And of course, during the pandemic, we had that great opportunity to share those stories, like the one I gave you, the gal that needed her trash brought in, or a gentleman who, he and his wife went on vents on COVID. She didn't make it out. When we reached him, he had no way he couldn't feed himself. He said, I don't know how to make, I haven't cooked in 50 years of marriage, right? So so it's easy for those stories to feed back into the staff broadly, and they love that. But how do you make them really connect what they do every day? So we created some gamification called the Amazing Marathon around the same personas that we're using in the targeting models of the cohorts. And we built cross-functional teams, and the game ran throughout the course of a year, and there were non-financial incentives and recognition, and a big thing at the end of the year. And it really brought those personas to life for staff that were working in really narrow parts of the business. And then they felt like what they did every day was meaningful. And so we were set actually to repeat that in 2020 with a version, that was Amazing Marathon, a version called Triple Summit. And of course, then we got into the pandemic era. So that was it was a great fun example of some of the work you do that's really inspirational, because you really are changing a culture in a really big culture in a very personal way.
Yeah, I love that. Love that. Topher, where do people find you if they wanted to follow up and learning more about that? You're on LinkedIn?
Yeah, I'm on LinkedIn. My organization, Chief Outsiders, I'm pretty easy to find on the page there. My name's reasonably unique until that famous actor that did Spider-Man showed up, Topher Grace. But I'm out there. I'm not hard to find, Eric.
I want to transition back to data for a moment here, because there is a question from the audience member that I probably should have asked prior to that empathy question. So it's a moderator one-on-one mistake. I'm going to bring in Louise to take a first stab at it, but then Cynthia, and Topher, you could jump right in behind it. From a member experience perspective, do you find value in mining appeals and grievances data? And if so, how do you approach identifying trends and root causes when this data may be inconsistent?
Yeah, so I would say absolutely take a look at that data. You can certainly find a lot of what's going on and going wrong, right, in that appeals and grievance data. To your point, though, if you're taking a look at it and you're like, well, there's something funny here, it's right. It's like sometimes you can say, well, the average is a 3, but then you peel back the layers and you go, really, there's this group of people who are ranking at a 1 and a group of people who are ranking at a 10. So what we have is like a wildly inconsistent experience. So trying to kind of understand, where are those inconsistencies and why? Those are often, in fact, if your spidey sense is like, well, this is consistent, I don't know what to do with it, I would say that's the time to dig deeper, because those are often the places where you really, crack open something that can transform your business. So for example, you might say, right, what we realize is that, it's about folks who don't speak English as their primary language. They're just having a terrible time, right? There's this pocket that's having this really awful experience, and these other people who are having a great experience. And then that becomes something that you can start to unravel and figure out how you accommodate that group, or how you sort of make that better. The one thing I would say too is don't, one, look at that grievance data, but also if you can, try to look at that bright spot data more critically. So sometimes if you're doing something like NPS, you tend to sort of say, oh, good. Oh, good. I got a good report card, right? And then sort of set that to the side. But I know, Eric, that's very much the spirit of this forum that you've created, is that if you look at those bright spots with the same criticality you might take to grievances, you can really learn a lot about what's working. And sometimes it can be higher value to fan the flames on something that's working and figure out how you can elevate it or extend it to the group that for whatever reason isn't able to access that value. So I would say try looking to sort of the extremes is almost what you're bringing up. Look at those people who are having a terrible time, look at those people who are having an excellent time, and try to dig into the why of it a little bit.
Amen. Cynthia, do you do the same? Do you do anything differently with your appeals and grievances data down there?
I think that the way we handle it is, appeals and grievances data is a pretty small data set in general. And so you're looking at, a very small subset of your population. And so what we try to do is a proxy survey. Some of it is CAPS-like, but some of it might actually dig into things where we suspect we might have a problem, where we want to learn more. And so we're getting some actual member responses to inform us and understand a little bit more about what's driving those grievances in appeals and ultimately member satisfaction and experience.
Right. All right. Cynthia, I'm going to come back to you in a moment because I do want to hear about what you would do differently for your Healthy Perks program. Before we do that, I want to get to that bright spot around the pandemic, Louise, and how that has accelerated a program or process and leveraged an organization to move forward. Well, while you're answering that, Sherry, I know Icario just published this white paper on achieving a record high member utilization and retention rate for quality health plans wellness programs. And I think it's a really interesting quick read with lots of big numbers and big letters. So it's like USA Today reading. I could read it and understand it. But it's an interesting take and blueprint on using a multi-channel approach to achieve high utilization rates with non-compliant exchange population. So if you want a copy of that, I'll send it to you via PDF, so you don't have to put in your registration information or anything like that, since of course we have it already. So you could just quickly poke at that. But why don't we talk, Louise, quickly about bright spots and what is a bright spot and how the pandemic has accelerated a program or process that should be scaled and leveraged moving forward?
Yeah, I think that's a really good question. The pandemic, there's so much terrible that's come with the pandemic, but there are some places where it's been able to sort of, break through inertia or introduce a new way of doing things. And certainly some of those things, we've been excited to see those accelerate. I would say one of the things that felt really interesting to me, and I'm curious, if Topher and Cynthia have seen similar things, is that I feel like we've seen an increase in acceleration of people kind of looking across their business a little bit more. So, quality kind of peeking over into the clinical side or peeking over into the sales side and saying, well, I have these goals. Are there some things happening over there that can help me with my goals and vice versa? Certainly this was happening before, but again, kind of at an accelerated rate. So one example I can give you, since we're on the topic of member experience, is that, a lot of folks, are trying to get an HRA. So you're trying to get a health risk assessment from a member. The sooner you can get that data, the better. The more people can use that data, the better. Often this function is driven by a quality group or a clinical group. And some of our clients took a look at that sales process and that onboarding moment when someone is actually at the point of sale for a Medicare plan, working with a broker or working with a sales agent, which by the way, tends to be a pretty one high touch experience and two, a pretty good experience. Salespeople are really friendly. Often that member will actually form a bit of a relationship with their sort of salesperson. So having part of that really high touch, really positive experience be, let's talk about you. Let's talk about your health. right? That even in itself feeling valuable to the member. You start to think, okay, so this is going to be a personalized experience. I can talk about what I want from the plan. I can talk about what I want going on. I can talk about my expectations. So actually capturing that HRA or health risk assessment at the point of sale, and then making some investments, just a little bit of investments in some technology and some integrations to make sure all different areas of the organization. So, Topher, earlier you were talking about complex case managers. How early can we get that information about who might need that? How early can we start to predict the volume that might be needed? So really making sure that that data, that reported data, is pulled into the areas of the organization where it can be most impactful.
Great. That's great. Folks, again, if you want to ask a couple final questions, please do through the Q&A module. Cynthia, let's now talk about your program again and what you would do differently if you had to relaunch Healthy Perks right now.
So thank you, Anna. So I think I'll start with my biggest redo idea really has to do with being too targeted, because we did have some members who we had tried to target specifically for hemoglobin A1C, and their friend or their spouse also was a diabetic, but we didn't have that information. And so Medicare members talk. And so then we would get the call from the friend or the spouse to say, hey, I'm a diabetic too. How come I didn't have the chance to do a hemoglobin A1C? We also tried to kind of over-engineer our goal of making sure that at the end of the year, the person's hemoglobin A1C was in control. And so we thought, well, if we could inspire them to do that early in the year, then maybe that gives them an opportunity to correct any problems that they're having with their hemoglobin A1C. So we tried to limit the time frame for the reward for hemoglobin A1C to the first 6 months of the year. And of course, that meant on July 1st, we had people calling and complaining because they could not get their reward for their hemoglobin A1C. And so we decided, keep it simple and not try to over-engineer things. And I believe we've had greater success that way. I think that we kind of came in with lessons learned when we decided to start the Healthy Perks program. That's what we do in quality. We do something, we study it, we tweak it, and then we either discard it or, use the new version. And so we already had a lot of lessons learned. And I think something that Lois said triggered a memory in my mind that historically we had sent gaps in care letters that were very educational, not fun, not exciting, not colorful, black and white, lots of words. And we realized that that's not the right approach, because you have to engage them first, to Lois's point, before they're ready to really begin learning. And so that's why we started the Healthy Perks program. And in addition, we've revamped our gaps in care letters so that they're much less wordy, much more colorful, and engaging.
So everything you learned, even after the launch, was based upon simplification. Make it less restrictive, make the words less wordy. Everything was just sort of simplifying it. So good advice, really good advice for folks.
Absolutely.
Launch a program. Incidentally, we have a couple of good questions. One about how to integrate the pharmacist more effectively that I'm going to put on you, Topher, in a moment. But one of our attendees, Jane Spire, she just added, she's worked for a Medicare, Medicaid plan, and where each member services staff was tasked with writing 5 handwritten thank you notes to members they had spoken to that week. And it was a great way of driving engagement. My sense is, this is not her words, but mine, but that's also probably a great way of incorporating empathy as a strategy, because you do tend to get very empathetic when you're writing those handwritten notes. So that's a great suggestion. Thanks for posting that, Jane. So a couple of questions here from the audience, and we'll hopefully end right on time, or maybe even a minute or two early. Topher and Cynthia and Louise, feel free to jump on top of these answers that Topher will throw at me. There are numerous studies showing the clinical and financial benefits of pharmacists, and Topher talked about that on the care team. But what are some of the barriers of getting them involved?
Well, in our case, we used a vendor that that lines up the pharmacist and is tightly integrated with our team. So that really helped to eliminate the kind of barriers and challenges to spin that up, sort of a package solution by a small specialist vendor that puts all the pharmacist team together. Then we just provide the tech and the scripting and the support is needed as I described.
Okay, so no new, and it's not Icario, right? It was a different vendor for specifically for pharmacists.
Yeah, it was specifically a group of pharmacists to provide support. Yeah, you just
got it.
Contingent labor kind of organization. Yeah.
Anyone? Any other additional follow-up answers to that?
I don't think that's.
I was just trying to say Louise or Cynthia. So last question. How do you guys track engagement and satisfaction for members with disabilities? And is that something specific that you ever carve out? Louise, do you want to start there? I'll start with you, and then Cynthia, if there's anything you guys are doing at AvMed, I'd love to hear from you as well.
Yeah, so from our perspective, understanding members with disabilities is pretty important. And I would say when we're conducting field research, that's often where we're trying to think. And so again, field research meaning you're out in the field, you're talking to members, you're in the member's home. And frankly, especially when it comes to understanding maybe some of your populations with disabilities. And I realize, in the pandemic that somewhat slowed this approach down. I would really recommend home visits if possible over, panels or surveys or things like that. To your point about designing from empathy, being in the home and kind of understanding how they're navigating things, what that experience looks like. You'll learn a million times more, right? And it will drive a lot more empathy. The other thing is people, and right, it's not like they're being deceptive. It's just, you don't really think about it. There's something about being in the home. You get a much richer and more honest story. So it's things like, if you start asking people about their health and they start saying food's important to them, and that's really how they try to stay healthy is, the way they eat. And then you say, can we take a tour of your kitchen? Can we look in your cupboards? The story that starts to come out when you're in their fridge and they're talking to you about their last shopping trip. That's when you start to really realize, well, how are things really working and where are your barriers? And, you're saying you do this, but in your cupboard, I'm seeing this. Let's talk about that. Is just a really great approach. So I guess maybe perhaps I'm changing the question a little bit, which is saying, make sure that you do certainly look at those populations, but this is a place also where I would say it's worth generating some data that you may not have. And that data comes from talking to them, spending time in their homes, following them around to their appointments, if you have a capability to conduct that kind of research in your company.
Cynthia, anything to add there?
I would just say that we do utilize in-home visits, both post-discharge and also for HRA completion. And I think that's very helpful for many of our members who either temporarily are homebound or more permanently. The other thing I might add to Lois's point about really being in the home and understanding the member is that we do actually have a new vendor over the last year or two who provides non-clinical people who can act as companions and helpers in the home. And they're also able to give information to our complex case management team, et cetera, when it's necessary. So I think we do have kind of a low-tech approach to that in certain ways, but it's a real reality-based approach of being in the home in several different ways.
That's great. Thank you for that. Folks, just a reminder to that feedback form has just landed in your inbox to please take it. It'll take about maybe 3 minutes to complete, and does help us in earning your trust each and every week with hot topics that are relevant to you, so that we could bring in guests to help you and inspire you to bring in new programs and new ideas into your organization. I want to thank our 3 panelists, Cynthia, Louise, and Topher for some great dialogue and conversation. I really appreciate all the time you took to prepare and all the time you took this hour to be with us in the middle of a busy work day and certainly a busy week. I know as we approach the holidays. Thank you to all of you who have joined us live and who are listening to us via the podcast feed. Really appreciate you participating through listening. And again, if you're on the podcast app, please do give us that 5-star rating and maybe put in a comment there. We do appreciate it. And we never take for granted the time you take with us to listen to an episode. This will mark the end of today's show. I'll ask my panel just to stick around for a second. Really appreciate it. Thank you. This has been Bright Spots in Healthcare.